So this patient's coming in for removal of a lesion that's been growing on his scalp, for quite some time now. This is somewhat mobile, consistent with a pilar cyst. So we've essentially done a circumferential block around here. I would draw attention to how lovely that haircut works with this. That's wonderfully done, by the way. Very nice and short. So it makes my job a lot easier. So here, Langer's lines run a little bit differently. So certainly there's the frontalis muscles coming across this way, but down to the back here, you can see it doesn't really squinch in any specific direction. So usually I'll just do like a horizontal incision here, which should work well from this perspective. No pain here at all?
No.
No. So whenever it's distended like this, I'm just always more careful than typical, only because this will typically want to sort of open up because the membrane's usually very superficial. So I just start very light, and then I just, essentially let just the weight of the blade sort of progress through that area. And sometimes it just doesn't take much, 1 or 2 passes, and then it'll actually open up. And so the more superficial it is, so the thinner that is, then the more likely it could rupture because it's thinner, which is fine. If it does, we can work with that. So the other thing always keep in mind when you are doing these, the scalp is quite vascular. So you just always want to be looking, or at least considering, how this is going to bleed, so you don't position the patient such as, so you can see here on this end, that's opening up there on this side here. See the membrane right there. Still very thin covering on top of it. Thank you. So that's where you can see the difference. I'll try to show you. Between right here, that's the membrane directly, and just distal to it here, there's still a very thin membrane over top of here, very small. That'll pull away as I open that up. You're still comfortable?
Oh, yeah.
So there you can see it better. So you see there, that's the membrane, but right, just tab that for me, Rada. Right through there, that's a little bit of extra membrane that's just right through there. That's small enough that I can actually pull through that, or I'll just sort of put this in this way and then work my way through it that way. So there you can see it, that little edge right there. That's what I'll just parse down through, just like that. So now it's just going to be a function of breaking down these adhesions. Looks pretty good. So this is where I'll reverse it. You sometimes see me pop this out. Might be, I might just put pressure on this one. Just put a little bit of pressure on it. Just like a baby. And that's that there. So you can see where it opened up on the side. So that's 100% complete. So there's just a little bit of a tear in there. I don't even know if I can grab this properly. just like we normally expect. So now we know it's completely out. You're still comfortable?
Oh yeah.
So here, this is just subcutaneous tissue. I'm just going to clip that out, just so that doesn't get in the way of our stitches. That looks pretty clean. So medium-sized ones like this, you can see how there's some redundant tissue here. Not enough that this shouldn't heal completely well, so this will feel a little bit boggy, probably for a month or two, but then that'll be right back down to his normal scalp. Slightly bigger, and then you would certainly be in a position where you would actually want to take, this is catching. Let's see if I can fix that. So this just knotted on itself. I'm going to pull that out. Deaden it. So in those cases, that's where an elliptical incision won't just make it a little bit easier in terms of taking it out, but it also has a better result at the end of the day. And obviously the reverse is also true. The smaller the lesion gets. So if you do an elliptical incision when it's a very small lesion, then having good opposition where the basement membranes line up will be a little bit harder because you've taken tissue out. So anyway, just a reminder that there's just pros and cons to each incision type based on the individual situation. And here I'll slow this stitch down again. Just dab that for me, Rada. So here's the V we always talk about. It's in through this area here. This is the V there. So on the inside, I'll just do 3 loops. I'll pull this through so I don't have much of a tail. Not as critical here because I'm only going to be doing 4 stitches, so I'll have extra, but you want to make sure you get in the habit of not wasting any. And then you want that to be lying just like that, so the 2 basement membranes are directly opposed to each other, but you're not getting buckling across the actual incision. If you get the sides overriding each other, it just won't heal as well, and you may have to revise that after the case. So this is why sometimes you'll see me pushing down on one side or the other. We certainly want to, when we finish this procedure, to make sure that it's well aligned. So here again, here's my V, just 3 loops. 3 loops self-locks. You could even get away with 2 here because there's not a lot of tension across this. And there's not a lot of tension because, again, we took mass out and we didn't do an elliptical incision. So this is going to want to sit back together. So essentially, I just want all the way across here that this lines up across where the actual margins come together, and that looks quite good. So we'll just put a dressing on that, and then we'll see him back in a couple weeks.